My name is Stephen Nowell. This is March 14th, 2022. I'm doing Unit 2 Case Connections video, and I will be answering case number 2 and case number 4. So I'm going to begin with case number 2. Although I cannot place myself in your shoes, I know it must be very difficult to grapple with your new diagnosis of muscle glycogen phosphorylase deficiency. To better understand your diagnosis, I'm going to tell you how this disease works and answer all pertinent questions you have. When the body is well fed and rested, it has the ability to store up energy in the form of glycogen. This glycogen is stored primarily in the liver and muscles and is essentially on standby for when your body needs energy. When your body goes into a fasted state, meaning it needs energy, then these glycogen stores will be converted back to glucose, which can then be used for energy. In exercise, the body will enter this fasted state because your cells will need energy in order to perform activity. In the muscles specifically, glycogen will be broken down when the skeletal muscles are active, such as with running, biking, swimming, or playing sports. Exercise causes several reactions in your cells that then lead to glycogen degradation to glucose, which then provides the energy for your skeletal muscles to use. Following your workout, your body will then use food, specifically carbohydrates, to help replenish your glycogen stores and provide energy for the next time you exercise. In order to break down the glycogen into the form of energy that we can use, glucose, your body uses muscle glycogen phosphorylase. Due to this deficiency of this enzyme in your body, it will make it harder to get the necessary energy to participate in strenuous exercise or activities. That being said, many new scientific studies have been released that state that carefully designed exercise regimens may actually be beneficial for patients who have this muscle glycogen deficiency. In most studies involving individuals in similar circumstances, there were definitive benefits gained from working out between 40 to 60% of your aerobic threshold and having organized training plans. These people were able to increase their activity over time. Moreover, those with this disease who avoided a sedentary lifestyle reported an improved sense of well-being and felt that they could better perform their everyday tasks, a point that I feel should not go unmentioned. As you had previously explained to me, you enjoy taking long walks. I believe that in accordance with your doctor's recommendations, it would not only be possible for you to go on long walks with your friends, but I believe that there may even be health benefits derived from this controlled exercise. In response to your question regarding waking up in the middle of the night to eat, the short answer is no. You will not need to wake up in order to get fuel for your body to keep your blood glucose regulated. The fact that your glycogen phosphorylase deficiency is skeletal is the reason you will not need to do this. For individuals who have liver glycogen phosphorylase deficiency, they may need to keep up with their nutrition, as most of the glycemic control is regulated by the liver. The absence of this enzyme for them can result in fasting hypoglycemia due to the inability to utilize glycogen stores in their liver. That being said, your deficiency is in your skeletal muscles, which will have little effect on blood glucose regulation. Lastly, excellent question regarding the buildup of excessive lactate during anaerobic exercise. Although this may sound counterintuitive, your condition will actually cause a decrease in lactate buildup when you are exercising. Due to the lack of glucose available, there will be a decrease in glycolysis, which is a system that our body uses to make more energy. One of the byproducts of glycolysis is lactic acid, specifically created when the body runs out of oxygen. Therefore, since the body cannot use the pathway of glycolysis, it will produce less lactate. Moreover, there is an additional pathway in the body, known as the Cori cycle, which allows our bodies to use lactate as a form of fuel. Studies have shown that individuals with your condition may utilize this cycle, harnessing lactate as the fuel, more frequently than those who do not need to rely on this method to produce energy. With that being said, I want to thank you for your time today, and I hope that my answers have helped you in some way. I know this new diagnosis is a lot to take in, but I want you to know that we would be happy to provide you with any additional resources or support you may need. The next case that I did is case 4. So a 2-month-old female patient has arrived experiencing jittery spells following breastfeeding sessions. and has not yet been introduced to solid foods. Additionally, this baby is hypoglycemic, meaning her blood glucose levels are low, and an epinephrine injection did not increase the blood glucose level, but rather caused an increase in blood lactate. Moreover, it is noted that upon entering the fasted state, blood glucose levels cannot be maintained. Upon physical examination, it is noted that the baby has hepatomegaly. Using a differential diagnosis approach, we will attempt to correctly identify the most likely culprit for these signs and symptoms. Our potential diagnoses are hereditary fructose intolerance, galactosemia, glucose 6-phosphate dehydrogenase deficiency, and glycogen storage disease. Our first potential diagnosis, hereditary fructose intolerance, is caused by a deficiency of aldolase B, which is an integral enzyme that is used to cleave fructose 1-phosphate into dihydroxyacetone phosphate, also called DHAP, and glyceraldehyde. DHAP and glyceraldehyde are intermediates used in gluconeogenesis, so without these, gluconeogenesis will be impaired. When fructose 1-phosphate begins to accumulate, it will also tie up free phosphate groups, which will decrease phosphate available for metabolic pathways. This depletion will decrease the effectiveness of the electron transport chain and will inhibit glycogenolysis. The symptoms due to these effects of fructose metabolism will be hypoglycemia. It will also cause hepatomegaly due to the toxic nature of fructose 1-phosphate on the liver. Although this diagnosis appears plausible due to these signs and symptoms, HFI is unlikely to be our diagnosis, as the baby has not yet been exposed to fructose, which would most likely be found through fruits or high fructose corn syrup products. The baby has only been breastfed up to this point. Additionally, the baby's lactic acidosis following epinephrine injection cannot be adequately explained. Therefore, we can rule out this diagnosis. The next potential diagnosis on our list is galactosemia. Galactosemia occurs when there is a deficiency in galactose 1-phosphate uridyl transferase, also called GALT, which is an enzyme that is used to convert galactose 1-phosphate to glucose 1-phosphate, which can then be used in the glycolytic pathway. This absence of GALT will lead to an accumulation of galactose 1-phosphate in the cells. This increase in G1P most commonly manifests with hepatomegaly, renal failure, cataracts, hypoglycemia, and seizures. In severe cases, there may be neurological impairment as well. These symptoms present are inconsistent with our patient's symptoms. Moreover, impaired galactose metabolism would be observed in the first few days of life, as galactose is readily available in breast milk, which is the infant's first form of nutrition. Due to the baby's late presentation of symptoms, as well as inconsistent symptoms, this diagnosis can be ruled out. The third potential diagnosis is glucose 6-phosphate dehydrogenase deficiency. G6-PDH is one of the main regulatory enzymes used in the pentose phosphate pathway and is integral in controlling oxidative stress and removing reactive oxygen species, which are toxic to cells, also known as free radicals. When G6-PDH is lacking, symptoms may occur when faced with increased oxidative stress, such as from medications or infection. Clinically, this has a propensity to cause hemolytic anemia and will manifest as jaundice, red and brown urine, as well as fatigue and weakness. Due to the lacking evidence of these symptoms, it can be reasonably assumed that this is not the diagnosis for the baby. Lastly, and what our evidence most strongly supports as a likely diagnosis, is glycogen storage disease. There are actually many different forms of glycogen storage disease. However, the symptoms associated here most closely align with glycogen storage disease type 1, which is also known as von Gerk's disease. Metabolically, this disease causes a deficiency in glucose 6-phosphate, which is used in the final step of both glycogenolysis and gluconeogenesis to produce glucose. The inability to utilize glycogen stores or synthesize glucose causes hepatomegaly, growth failure, fasting hypoglycemia, acidosis, and lipemia, all symptoms that our young patient is experiencing. Additionally, epinephrine was ineffective in raising blood glucose levels due to the impaired gluconeogenesis cycle, thus causing the increase in blood lactate. Moreover, In many cases of G6P deficiency, patients often present around 3 to 4 months of age, which further gives evidence in support of this diagnosis. Due to the symptoms present in this baby, the timing of admission, this diagnosis for this baby is most likely glycogen storage disease.